Okay, everyone, good evening, and thanks very much for joining us. My name's John. I'm one of the doctors for Cheshire and Shropshire Immediate Care Group and the Education Officer. Um, and I'm just going to be introducing Adrian tonight and his topic. Just before we start, just a little bit about who we are in Cheshire and Shropshire Immediate Care Group. We're part of a national charity called Basics. We're an accredited scheme within that national charity. We're made up of paramedics, doctors, and nurses, and all of us have various enhanced skills within the field of pre-hospital care. We've got two main aims. We want to help out the ambulance service to provide uh, uh, life-saving interventions within our local area, and also the reason why we're here tonight is to provide education and training to anybody who works within the field of pre-hospital care. We don't get any government funding. We rely completely and solely on donations, and none of us are paid for any of what we do. So we've set out a bit of an educational agenda for 2021. It's had a bit of a slow start because of things that are going on at the moment. Um, but these are just some of the topics that we've identified and hope to cover over 2021 and probably into 2022 as well. And I think you'll agree with some pretty good and exciting topics there. Those topics have been roughly mapped to the curriculum for the Intercollegiate Board for Training in Pre-Hospital and Emergency Medicine. Um, this is the curriculum that you would follow if as a doctor, you were going into the FEM training curriculum. One of the things we want to try and get off the ground is a FEM journal club. So this is an opportunity for any of you guys. If any of you, any grade, any speciality, want to either work on your presentation skills, um, or your critical appraisal skills, or if there's something that you've noticed in the literature for pre-hospital care that you'd find interesting and you want to talk about, then we'll give you the opportunity to essentially host one of these webinars and talk about whatever article it is that you found. If it's something that you've never done before, that's absolutely fine. Let us know, and we can take you through it. We can take you through what's involved in a critical appraisal. We'll make sure there's a certificate as well for you, so it's good CV building stuff. These webinars will always be free. It's not costing you anything tonight, and it's not going to cost you anything going forward. But this is the big plug. This is our fundraising plug. This is where we get our message out about what we do. And if you're interested in helping us and supporting us as a charity, one of the biggest things that you can do for us is to join our lottery. So we signed up to this group called One Lottery. If you go to their website and search for Immediate Care Group, it will take you to our page. And you can sign up, and there's a draw every week. You might win £25,000, and there's some various other prizes as well, and smaller prizes each week as well. So if you're interested in helping us, that would be absolutely fantastic. This is our website, csibasics.org.uk, and you've all got my email address because that's how you've contacted me. What we'll do is when Adrian's presentation has finished, I'll facilitate a little Q&A session for you. And if you are watching us on the Click Meeting platform, when you exit the webinar, it will ask you for a little bit of feedback. So if you just spend a minute or so of your time just putting a little bit of feedback in there, it's really, really useful for me to know if there are any problems, anything that you want us to cover in the year going forward. And anything that would be really useful for Adrian as well for his feedback for the session. And if you're interested in that journal club that I mentioned, then please do email me on my email address, and I can make sure we get a session booked in that's convenient for everyone, and you get the opportunity to present something. Okay, Adrian, I'll load up your presentation, and I'll hand over the reins to you.
And thank you very much, John. So good evening, everybody. For those who don't know me, I'm Dr. Adrian Marsh. I'm a consultant in emergency medicine. I have been involved in the pre-hospital environment since 2007, I'm presently a trustee for CSI Basics. I was asked by a paramedic to do some education on hypothermia. So this is where tonight has come from. There is a disclaimer at the start of this. This is the best evidence that I could find. I'm very much aware tonight that there are people here from 3 ambulance services across 2 countries. We've also got some medical students and some junior doctors as well. So please remember that your actions are governed by a professional body, and you do need to follow your local guidelines and your local protocols. So I'm going to try and do an evidence-based talk as much as possible. So where there is evidence out there, we will grade some evidence. I'll give a little bit of background about hypothermia, some of the causes, how to stage it, some of the pathophysiology, assessment treatment, what we do in hospital, and then some special circumstances at the end. So for those who aren't particularly aware, this is how evidence gets graded. Level 1 is the large randomized controlled trials, which have got very clear-cut results. Level 2 is the smaller ones where results aren't particularly clear. Level 3 is the case control, and actually where we just got a group of people together. Level 4 is historical data, and then 5 is the case series. You then put that together, and then you end up with grading from A to D, where grade A is a strong recommendation, B is recommendation, and C and D, you actually essentially need to take it into account and do what's best for the patient. And what we'll find tonight is a lot of what we do for hypothermia, there isn't really huge amounts of evidence behind it. And I'm going to put an apology before we get any further. The world is what the world is at the moment. I will try and minimize use of the C word as much as possible tonight. I accept this will be quite difficult. This is a talk on hypothermia, so the word cold will come up quite a lot, but we will try and actually use it as little as possible. So why hypothermia? There's actually quite a large incidence of hypothermia in the UK. This is 2017 data, and we reckon that actually about every 6 to 8 in every 1,000 patients actually has hypothermia. And in 2017, up in Scotland, there were 34 deaths that involved hypothermia. There are lots of causes, and the most obvious one is cold exposure. We are in the middle of winter at the moment. In hospital, massive transfusion, dialysis and surgery. And then there's other things that people don't tend to think about very much. Sepsis is actually really important. So if you take the same patient who's hypothermic or has actually got a pyrexia, actually your risk of mortality if you're hypothermic is significantly higher. So it's just to sort of bear it in mind. If you look at the nice red flags for sepsis, hypothermia is a flag, but a temperature is not. Also associated with pancreatitis. And then there's a whole lot of metabolic problems, hypoglycemia, DKA, hypothyroidism, adrenal insufficiency, thiamine deficiency, which fits with alcohol use, and anorexia nervosa. So when patients have actually got a low body weight, actually they tend to run very low temperatures as well. And this group often running temperatures normal for them, about 34 to 35. Ethanol, very common. Opioids, and then lots of medications. We put elderly patients on beta blockers, alpha blockers for people normally having urinary retention, prostate problems. Again, very common this time of year, especially in Shropshire, where everybody has wood burners and doesn't get the boilers checked. It's carbon monoxide poisoning. And then spinal cord injury, MS, Parkinson's, and CVAs that affect the thalamus. So not all hypothermia is due to exposure, which is probably the key point to take away from this. So you actually have to think a lot wider and actually outside the box of actually what's actually causing it. Now, accidental hypothermia, which is actually exposure to the cold, is one of the most common reasons people get hypothermia, and it is a life-threatening condition, and it can lead to very, very challenging resuscitation. And just so we're all talking about the same thing, is defined as a core temperature of below 35 degrees Celsius. So this was Shropshire on Sunday. You can see how if you slipped over, this was up the top of a hill. You may not be found for hours. You could get cold very, very sort of quickly. And also to be rescued from here would actually be technically challenging as well. As up here, there was no road access for about 2 miles up a steep hill. So it's not necessarily just the hypothermia itself, as we'll go through later, that can make it very challenging, but it's also where the location of the patient is as well. So there are lots of causes for heat loss. Most of it is radiation. So we produce heat, it radiates away. When we're working hard, it's evaporation of sweat. You then actually just lose heat as well, just to the air. And then there's conduction to the objects that you're sat on, or wet clothing. There's lots of stuff done back in the 1970s, which suggested that actually you lost about 40 to 45% of your heat through your head. This is actually a myth. This was actually what they did was it was a US Army survival experiment, but they actually put them all in Arctic survival suits. And essentially, they were covered from neck down. So when they looked at the thermal cameras, all the heat loss, unsurprisingly, was from the head, but it's not as much as 40 to 45%. There was a report back in the BMJ in 2008 that actually suggested it was about 7 to 10% of the body heat is lost through our heads if everything else is covered. So although really important, it's not quite as important as we were actually once led to believe. So I don't know who knows this person. This is Wim Hof, who's actually quite famous at the moment, who is, I think he's Danish from memory, is an athlete who actually believes in cold showers and breathing exercises. So unless you follow the Wim Hof method, it's not a plug for his book, my conclusions were, if it's cold outside, you need to wear a hat, don't go outside naked, and if you've got some hypothermia, actually covering the head to reduce heat loss actually is really quite important. Now, there's different ways of actually staging hypothermia. There's mild, moderate, and severe, which is what lots of people actually use, lots of guidelines use. The Swiss model uses grading from 1 to 5. So HT1 is a hypothermia level 1, 2, 3, 4, and 5. And this essentially is defined as mild. This is the point where you're conscious, you're shivering, and your core temperature is typically about 32 to 35 degrees Celsius. When you get moderate, at this point you actually become quite confused, and you then stop shivering. By the time you get to severe, you become unconscious, you do have some vital signs, and this is actually below 28 degrees Celsius. Severe, or number 4, using the Swiss model, is apparent death, where actually your vital signs are absent, and we'll come back to this in more detail later. And then, although not used in the UK, actually is death due to irreversible hypothermia, and depending on which paper you read, there's either your core temperature less than 13.7 or less than 9, but there is no actual agreement on either of these. So we're going to sort of talk a little bit more in detail what happens as your temperature drops. This is not an absolute. There is some crossover at different degrees, and everybody is actually different. It depends partly actually on the person, on their acclimatization. So this is not an absolute, but this is a guide. Because as you get colder, actually the thermometers actually are less accurate. So the ones that actually temperature of the dependent membrane actually don't work at a low temperature. So you can use this as a rough kind of guide, but as I said, it's not an absolute. So by the time you hit 35 degrees, you actually start to shiver. You can then get a little bit confused. As your temperature goes down further, your body actually tries to compensate. So you actually get a tachycardia, you get a tachypnea, you actually get increased systemic vascular resistance, and all of this actually drives more blood through your kidneys. So you end up with cold diuresis, so they end up dehydrated. As they get colder, you then end up with a bradycardia. You the respiratory rate starts to drop down, and then you get hypoglycemic, so your blood sugar actually goes up, which then can get quite confusing because, as I said before, one of the other things that presents with hypothermia can be DKA. And so it can be quite difficult to actually work out which one it is. When we talk about rewarming, it becomes a little bit easier to try and work it out. But actually, in the pre-hospital environment, you may never know. By the time you hit 32, people are very lethargic. And at this point, you actually stop shivering. By the time you hit 31, most people have an atrial arrhythmia, and you get Osborne J waves on your ECG. And on the next slide, I'll actually show you what they are. Interestingly, nobody actually knows why they happen. Lots of theories out there, but there is no definite answer of why. You get more and more bradycardic. By the time you hit 30, your natural insulin is no longer effective, but actually you begin to get decreased oxygen consumption. And then as you get below 30, 29, you get more and more drop in your GCS. Your pulse gets slower and slower, and your respiratory rate gets slower and slower as well. So we're talking about Osborne wave. So this essentially is a normal ECG. So you've got your P wave, you've got your QRS complex, and you've got your T wave. And this point here is called your J point. And some people have an elevated J point, especially young males. And then you can hopefully see this one here. So this actually is your J wave. So rather than coming up, down, and back up again, it comes up and then it comes up before going back down. It's slightly better demonstrated on the next slide. So this is somebody who has got hypothermia. The rate is slow. You come up, you come down, it comes back up, you come back down again, and this bit here is your Osborne wave. As you then progress into severe hypothermia, by the time you hit 28, you begin to get an increased risk of ventricular fibrillation. Your oxygen consumption is actually decreased by 50%. Then at 27, you actually lose all your reflexes and you lose voluntary movement. By the time you hit 26, there's no response to pain. Now, the good news with this is by this point, actually, your oxygen consumption by your brain and your heart is significantly lower. So actually, your body copes reasonably well, actually, with a decreased heart rate, decreased oxygen supply to the tissues. You can start to get pulmonary edema and you get apnea. 24, your blood pressure is significantly low. 23, you no longer have your corneal reflexes. Time hit 22, you've now hit your maximum risk for going to ventricular fibrillation, and your oxygen consumption is only about a quarter of normal, which is just as well because by this point, people aren't actually breathing. And this is one of the reasons when we talk about resuscitation later in this talk, actually people do tend to have a positive outcome with good neurological outcomes and ability at the end. And this is the reason why. So first steps. So as always, and I know I'm preaching the converted here, your safety is always the first priority. Once you know the scene is safe and you can approach without getting caught, trapped, injured, the next question is the patient cardiac arrest. If the answer is no, and I'll go through the steps in a little bit more in just a minute, You need to take steps to avoid cardiovascular collapse, because if you stand them up, they will have a cardiac arrest or high risk of a cardiac arrest. We then need to prevent any further decrease in core temperature and then re-warm in a safe manner and a safe environment. So this I have stolen. So this is the Wilderness Medical Society, who essentially are based across in Canada, who deal with large amounts of hypothermia, far more than we do in the UK. And this is actually their algorithm, which I think is actually quite nice. And this is why I've put it up. So you start up in this corner up here. And this is the patient who's cold, but is not hypothermic. So this is a patient who has got a core temperature of more than 35, but feels cold. And this group, you put some more clothes on them, you actually give them something hot to drink, and you actually get them up and walking around, and actually they will recover and nothing else needs to be done. By the time you hit mild hypothermia, they're still conscious. Okay, they are still shivering and they're still alert. And this is a group that you want to handle gently. So he says the temperature gets lower and lower, you begin to increase your risk of VF. You want to lay them flat. You actually want to reduce any further heat loss. Give them a warm drink. And if possible, if you've got anything with you, which you actually absolutely accept, people may not have them, start to warm people up. And they want to use some heat packs. They need to be across the chest and across the axilla and not down the peripheries. And after 30 minutes, to begin to warm up, you can begin to gently get them up and get them about. By the time you hit moderate, they're still conscious, but you look at this, they're no longer shivering. You begin to lose a voluntary movement. Handle really gently, keep horizontal, kind of wrap them up. Okay. Essentially, if you have some warm fluids, and actually in the UK, I know lots of ambulance services don't have warm fluids on the back of the ambulance, and actually evacuate safely. And by the time you hit severe hypothermia, are they in cardiac arrest? And we'll talk about transport a little bit later on this talk. You need to check for at least a minute. So it's not the 10 seconds that we're teaching in ALS, it's for a full minute. And if anybody's got an ultrasound probe with them, and I know some people do out there, you're actually ideally looking to do an echo to see if you've actually got any evidence of cardiac movement. Now, there is a little bit of concern out there about after drop. So after drop is actually where the core temperature actually drops as you actually begin to warm the patient up. This is essentially because as you begin to warm them up, as they're cold, all your peripheries close down. So the body is trying to keep all the warm blood actually in your core, around your heart, your lungs, your kidneys, and up to the brain. And everything peripherally shuts down. So actually, as we begin to warm up, you get the cold blood that comes around from the peripheries, and this actually therefore will drop your core temperature even further. And this happens if you stand people up. This happens if you start walking people, you've not began to warm them up, and if you do active or passive limb movements. Now, how bad is this? Some studies reckon that actually you can drop the core temperature by a further 5 to 6 degrees, which is a significant amount. If somebody's already got moderate hypothermia, they can end up having severe hypothermia. You can increase their risk of VF. However, that was done quite a while ago. There was, in the last kind of 5 years, there's been some avalanche burial studies. So essentially what they got people actually essentially in suits. They actually buried them in snow. They put a breathing pipe in like an oversized straw, so they didn't end up breathing their own carbon dioxide. Did core temperature measurements while they were buried. I wouldn't want to volunteer for that one. And then they actually then took them out and rewarmed them. They didn't get as much as 5 to 6 degrees, and after drop it was about 2 to 3. And it was short-lived and lasted under 15 minutes. So after drop definitely does exist, but actually the degree and for how long is presently still being debated. But I think the key take-home message here is that actually you need to be prepared for it, because actually at the point you actually mobilize the patient or actually start handling the patient and move them around, you might actually make the hypothermia worse. So there's some grade B evidence around this, around gentle handling. And this is the reason why, as I said before, as you get more hypothermic, it lowers your threshold for ventricular fibrillation. As you increase your blood flow to the core, your temperature goes down. And right at the start, I said your systemic vascular resistance goes up. So you've already got a heart that's now really kind of struggling against the resistance, and it's pumping ineffectively, and actually therefore putting more blood back in, and you're overstretching it, and therefore it can't contract properly. So this really goes without saying, is prevent further heat loss. So ideally, if outside, as safe as possible, and it's difficult when people are entrapped in cars, trapped up a mountain. It means to try and move them safely from the environment. Remove wet clothes and minimize further heat loss. So we just need to remember, actually, if you've got somebody on the sheet and the sheet has got wet, that will still kind of act as a conduit, and they will still get cold because of the cold sheet. So actually, once I've actually got the wet clothes off, they absolutely need to be on a dry sheet. Field rewarming, again, depends where you work. There's different rates out there. Some guidelines say 0.5 degrees per hour. Most of the evidence, the guidelines out there suggest that 1 to 2 degrees per Celsius per hour is safe. And actually, if you're shivering by yourself, you can actually raise your core temperature by about 3 degrees in an hour purely by shivering. So how are we going to rewarm them? Ideally, shivering is a really good mechanism if the patient can actually tolerate it. It increases your heat production by 5 to 6 times the normal metabolic rate for that person. However, it does use a large amount of energy, and this is why the guidelines suggest you need a high carbohydrate liquid or food. So the first aid of giving them a hot cup of tea with some sugar in it absolutely holds true. And they need to make sure they're adequately insulated to prevent further heat loss. And I will show you a little diagram in just a second. Absolutely need some exercise. So you need to allow that patient to shiver and rewarm whilst insulated prior to getting them up and getting them walking. The guidelines say it should for at least 30 minutes, but actually there's no good evidence behind that. That is consensus view. And obviously monitor closely at the point where you actually stand them up and get them to walk around, because despite letting them shiver, stopping any further heat loss, have them out of the wet clothes, actually they can still get some after drop, which actually may cause the situation to be worse. External heat source needs to go ideally, again, not the peripherals, explain why, but actually needs to go into the axillae, on the chest, and actually on the back, because you want to keep all the warm blood in the center. And obviously, if you rewarm, the risk of burns, so it needs to be checked on a regular basis. And again, no good evidence for why 20 minutes, but that's what most of the guidelines actually suggest. Rewarming during transport. So there's been quite a lot of studies done on this. So somebody who is unclothed and actually has a normal temperature, in a background temperature of 28 degrees, you'll actually not lose or gain any heat. So 28 is the kind of cutoff point to actually for someone not get any warmer or get any colder. However, most of the guidelines suggest that it should be around 24 degrees, because actually if you're kind of working at 20 degrees, you get really hot, really sweaty, you can't function, you get dehydrated. So most of the guidelines say that actually the cabin temperature should be at least above 24 degrees Celsius. IV fluids are always a bone of contention. I absolutely kind of get that. So if you take a 70-kilogram person, and then convert that into liquid, that's about 70 liters. So if you have 70 liters in your bath and you put in 250 mils or 500 mils of warm saline into that bath, it's not really going to change the temperature actually of the water. So actually, when in a hospital, all the fluids are warmed and put through a fluid warmer. So just because they come out of the warming cabinet doesn't keep them warm, because then they've gone down the tubing and into the patient, they've actually got quite cold. Then you have to go through a warming box. And this essentially is not really done to actually warm the patient up. This is just done to actually maintain the core temperature. So cold IV fluids will just make your bath even colder, in this case, the patient. So before you give IV fluids, the question is, do they really need it? Because actually you might make the hypothermia worse. It's just something to think about. I'm not saying don't give them. That's not what I've said. But you do just need to actually consider actually why you're giving it and actually what benefit are you actually looking for. So pre-hospital wrapping, I quite like this. Again, this is from Canada. This is from the Wilderness Medical Society that have produced national kind of guidelines. So they've got the heat packs, axilla, chest. They've then got essentially an insulated foil blanket, and essentially burritoed the patient in it. And then they've actually taken another layer across the top and actually folded it in again. And they've put a hat on the patient. Again, so it is kind of really whatever kind of works. It's whatever equipment that you actually have. I just quite like this as a diagram for demonstrating kind of sort of multi kind of layer sort of wrapping of the patient with an insulated layer as your base layer to actually try and reflect any heat they generate back in, insulate them from any further loss. So what happens in hospital? So this is what should be happening in hospital. They get a full ATE assessment. What's the cause of the hypothermia? As we said right at the start, there's lots of reasons for hypothermia, and it's not always obvious the reason why. And quite often that you actually may have more than one thing at a time. So you may have a patient who is on a beta blocker, who's gone out into the cold and drunk a whole lot of alcohol, and then ends up sitting down or collapsing, and therefore ended up hypothermic. Or somebody's gone out for a run, fallen over, broke their ankle, and ended up hypothermic. So in hospital is, what's the cause? Are there any injuries? Measuring core temperature, and actually this is more difficult than you actually think it is. Said the tympanics actually don't really work. In an ideal world, you want an esophageal probe. So essentially, the probe either goes down the nose or into the mouth and actually sits down just above the stomach. But the patient requires to be intubated to actually tolerate this. So quite often, actually, either a rectal or a bladder thermometer is actually kind of used. However, these do lag behind the core temperature quite significantly, and these may miss after drop. So it's just to actually just be cognitively aware. The other thing with rectal thermometers, they're not always, although they believe to be accurate, actually, if they end up in feces, then actually, again, your temperature measured will be that of what they're in, actually, rather than the pure core temperature. Oop. So whole investigations are done. Glucose, ECGs, using and calcium, full blood counts, lactates, clotting, CK, amylase or lipase, an ABG, and a chest X-ray, and then whatever else is dependent on the case, and I'll explain why. So hematocrit. So normally hematocrit goes up by 2% for every 1 degree Celsius drop in temperature. So actually, therefore, if you have a low or normal hematocrit, then actually that's abnormal. So that suggests that the patient was anemic beforehand or has had a significant bleed. So normally, if you have a bleed, your hematocrit, your HB actually doesn't drop immediately. If you take a fish bowl and actually put sugar puffs in it, which look like red cells, you can actually use anything you like. Other cereals are available. If you scoop out your water and your sugar puffs in this case and measure the concentration of your water to your breakfast cereal, it's the same. You have to top the tank back up before you actually get your drop actually in hemoglobin. So due to the insulin that doesn't really actually work, actually most people will actually be hyperglycemic, and actually as you warm them up, if they remain hyperglycemic, it's suggestive of either pancreatitis or DKA. The other thing to remember is that the ECG changes that you get actually can hide hyperkalemia. So in hyperkalemia, one of the first signs you get is a peaked T wave, but actually you don't get that in hypothermia. So actually you may be missing hyperkalemia. And then for those of us who actually work in a hospital, when you send the coagulation screen up to the path lab, they warm the blood at 37 degrees. So you actually may end up with normal clotting results, but the patient may be actually hemorrhaging significantly. And as they get cold, they don't clot properly because it's an enzyme-driven pathway. And they all get ongoing ECG monitoring to look for dysarrhythmias. So rewarming. So mild hypothermia actually is passive external rewarming. So that's what we've described before. Warm blankets, give them a hat, give them something hot and sweet to drink, and actually let them shiver, let them warm themselves. By the time you get moderate hypothermia, we actually now begin to do some active external rewarming. So there's a forced hot air blanket. There's lots of commercial brands out there, but essentially it's a blanket that goes over the top with warm air that sort of feeds through. And then in severe hypothermia, we start doing some active internal rewarming, which I'll go through in just a minute. So internal rewarming, there's a couple of things that can be done. Is you can put a catheter in, and you then put your warm fluid into the bladder. So you put sort of 200, 300 mils into the bladder. You leave it for 20 minutes. You drain it back out, and then you repeat. All right. You need to remember to do it. I've done this once in a patient who came in actually in cardiac arrest. And actually, when you drain the fluid back out, it comes out icy cold. And this will only really give you about 0.5 to 1 degree Celsius increase per hour. Not really used these days as a gastric lavage. You put a nasogastric tube down. Again, you fill the stomach full of hot water and take it back out again. High risk of aspiration and huge electrolyte shifts. Thoracic or peritoneal lavage. So this actually tends to be really done in people in cardiac arrest. So actually tends to do it more on the right hand side, the left hand side, because of where the heart sits. You need to put 2 chest drains in. One ends up kind of high and anterior, other one ends up low and posterior. And since you need a sort of fluid warmer, and you put the warm fluid in through the top chest drain, it circulates around your pleural cavity and then drains out your bottom drain. The other thing you can do is put a dialysis catheter in, so that she's just actually above the umbilicus. You put a little catheter in. You can then put a couple of liters of warm fluid into somebody's abdomen, and then you can drain it back out. High risk of lung injury, bowel injury, and if you've got lots of fluid in the thoracic cavity, it can impair your quality of your CPR. Then you can do venous hemofiltration. So they end up on a machine that essentially sort of spins the blood and warms the blood up in the process. And you can get about 3 degrees per hour on this. But your patient needs to be able to actually put the cardiac output up as you take a volume of blood out of them. And you also require to anticoagulate them. And then ECMO. So ECMO, the two closest centres around here is Leicester and Manchester. And these are useful in a cardiac arrest. I don't know what the centres are doing at the moment, to be honest. But actually, this will warm your blood and oxygenate your patient. And you can actually re-warm your patient about 4 to 10 degrees per hour. So resuscitation, actually, there are lots of case reports of hypothermic patients who've survived neurologically intact. And the way that we normally kind of predict death, fixed dilated pupils, rigor mortis, dependent lividity. So that's when you kind of actually see the blood kind of pooled on the surface, it's down, are actually in hypothermia, are completely unpredictable indicators of death, and they're not a reason not to start CPR. So pre-hospital, check signs of life, I said, for 1 minute, not 10 seconds. Start CPR if on ECG there's a non-perfusing rhythm, e.g. VF, VT, or asystole. If you've got PEA, then essentially assume you've got there is some form of cardiac output, in which case, if you've got end-tidal CO2, then actually you want some end-tidal CO2 in the circuit. And if you don't, then you'll just have to assume that they're going to cardiac arrest. And there are teams out there that carry ultrasound with them, and in which case you want to look for cardiac contractions. So you're trying to actually look for signs of life beyond what we normally do. So ECMO, the world we're at the moment, I don't know what the ECMO centres are actually doing. If you work somewhere close by, it's probably worth finding out. International guidelines suggest that if you've got a patient with severe hypothermia, and if either they've actually got systolic less than 90, ventricular arrhythmias, or your core temperature less than 28, they should go to an ECMO centre for consideration of ECMO. And in cardiac arrest, again, the international guidelines suggest they should go to an ECMO centre if the core temperature is at or less than 30, and the potassium is less than 12. Intubation. So absolutely, all the airway studies actually have very much said that actually an LMA is as good as an ET tube. Unfortunately, in hypothermia, the airway pressures are significantly higher. The chest compliance is really very much stiffer. So actually, this group actually may need to be intubated to actually be able to get enough pressure to achieve effective ventilation. There is an increased risk if the patient is actually in a perfusing rhythm of actually triggering VF at the point of intubation. So they're not easy to do, and they actually do come with significant risks associated with it. And again, it depends which ambulance service you work for. Mechanical CPR actually may be a useful tool around the duration of quality CPR that may be required. And the guidelines that I've seen that are the international kind of guidelines suggest that if continuous CPR is impossible, i.e. to move the patient, and you're in an austere environment, that actually 5 minutes of CPR to 5 minutes of moving if your temperature is above 20 degrees, and it's 5 minutes of CPR to 10 minutes of moving time if your temperature is less than 20 degrees, and this is based on a couple of cases and reports where actually people have actually had a ROSC and have had a good neurological outcome by using those strategies, but it is purely based on some cases and not much else. Defibrillation, if the temperature is less than 30, You're allowed to attempt up to 3 shocks. If at this point you still haven't got a return of circulation, then actually the ALS algorithm is you don't give any further shocks until your temperature is at or higher than 30 degrees Celsius. The thought behind this is you're just going to cause myocardial damage from your defibrillation, and it's clearly just not going to work. And then drugs, essentially avoid all ALS drugs until your temperature is at or above 30. We could debate adrenaline on a different day on the paramedics 2 study, but essentially the ALS algorithm says avoid all ALS drugs in temperatures more than 30, because the suggestion is that actually they just won't work. And then between 30 and 35 degrees Celsius, ALS says you need to double the time between your doses. And this essentially is because it takes so much longer for the dose to actually get round the system. So I said before, actually fixed pupils, levitii, rigor mortis actually is not an indication not to do CPR. Again, these are national guidelines that I found. So essentially it says when to stop or not to start is the body is frozen or the chest is incompressible. There's other lethal injuries where hypothermia is not the most likely cause of death. Potassium at or greater than 12. To date, there's not been a single patient whose potassium is more than 12 has survived. Or asystole despite a temperature at or greater than 32 degrees Celsius. There are some little changes that, depending on where you work, I accept that having an avalanche in the UK is highly, highly unlikely. But essentially what they said is you need to try and actually determine the burial time. And if there's an air pocket around the patient, when they've looked at this in countries where they've got high risk of avalanches, actually the bystander time of avalanche isn't really reliable. From the studies and from what they think's out there, a burial time of under 15 minutes, your survival rate is approximately 70 to 80%. At 35 minutes, your survival rate is between 7 and 32%. If the burial time is under an hour or it's over an hour and they're not in asystole, you then follow normal ALS procedures. If the burial time is essentially greater than 60 minutes and asystolic, actually the first thing to actually do is look at the airway patency. Okay, if the airway is impacted, i.e. when you're looking if there's snow in the oral pharynx and there's no air pockets, so i.e. there's been no kind of cavity around that patient, then do not resuscitate. If there's a patent airway or the airway patency is unclear, measure potassium. And in an avalanche situation, the cutoff is not 12, but the cutoff is 8. And again, to date, there's been no patient with a potassium of 8 or higher that has survived in this circumstance. Drowning, we do get lots of drowning. So there's a difference between immersion and submersion. So immersion is just when they've ended up in the water. And actually, outcome from those is actually very, very good. Submersion is actually when the head is under the water. So don't start CPR. It's been submerged more than 30 minutes and the water is more than 6 degrees Celsius. Submerged more than 90 minutes in water and less than 6 degrees Celsius. And stopping CPR is 30 minutes in adults if you have not had a ROSC, if temperature is more than 6 degrees, and in children it's up to an hour. We're going to move on away from hypothermia for the last couple of minutes, and we're just going to talk about freezing and non-freezing injury. So frostnip, we've all had frostnip for anybody who's been outdoors. This is where you're kind of outside in the wind, the snow, the rain, and the tip of your nose goes really cold. It's really kind of sore and it goes white. And these all get better as soon as you warm your nose back up, or the tips of your ears commonly. Frostbite is the next kind of, sort of stage from frost nip. It's a freezing injury. You get vasoconstrictions where the blood vessels clamp down, and therefore you don't get enough blood supply. Ongoing exposure, you get ice crystals that form, and this then causes occlusion in the microvasculature, so in all the capillaries. And actually, if you've got frostbite, you need to leave it be until somewhere we can actually warm it back up and not refreeze. The injury is a lot worse if you get partially rewarmed and it then refreezes again. There's a grading system. First and second degree is superficial, third or fourth is deep. It's done sort of two ways. So first degree is where you get some swelling, pallor, and a bit of actually some redness as well. There's no blisters, and there's none to very minimal tissue loss. Second degree is where you start getting clear blisters that form, looks like a bit like a burn. And the blisters often come at 6 to 24 hours after they've been rewarmed. You then go to deep. So now you get hemorrhagic blisters. So you get blood in those blisters. You get black tissue that forms, and this forms over weeks, and you get tissue lost. And then fourth degree is where you get muscle and or bone involvement with loss of that as well. So this is what they look like. This is first degree. You can see on this one, you've got clear blisters with hard skin. You've now got blisters which have got blood in it. And you've now essentially got skin loss, essentially right the way down to the bone. Treatment, treat the hypothermia. You prevent refreezing, protect from anything else, and then these should go into a hot water bath. You can then essentially work out actually where they're at. They get some analgesia, tetanus prophylaxis, antibiotics, and surgery if it's a deep or a grade 3, grade 4. Also, there's lots of non-freezing injury, and actually there's quite a lot of this around. So trench foot, which is immersion foot, is where you end up with wet feet above 0 degrees Celsius. Comes in 4 phases. You kind of get numbness with pale white skin from vasoconstriction. Then once the cold is removed, the skin becomes blue and mottled. You then get intense pain and goes red. And then you end up with kind of changes in the sensory and motor changes. And this can actually last for weeks to years actually afterwards. This is what it looks like. So they get moved to warm, dry environments. Limb gets elevated, and these get essentially allowed to air dry at room temperature. And then the last thing is chilblains. So these are kind of little localized kind of inflammatory lesions, kind of little kind of sort of red sort of spots. Commonly affect hands and feet within 24 hours of damp and cold. Interestingly, young women, children, low body weight, and things like SLE put increased risk. Get kind of sort of numbness, they get itchy, they can be quite painful. There isn't huge much treatment for these. They need to stop smoking if they smoke, keep the area warm, and then they tend to get better over weeks to months. And this is what they look like. And I just do some acknowledgements. So to John, who's done all the work behind the scenes, who set this all up and actually has run the IT tonight. We have done this plug on at the end as well. CPD is given free of charge. The charity, we're not able to support the ambulance services and patients about donations. And here's the website if you wish to know any more. So thank you for listening, and I think we'll do a quick, we'll do sort of 5 minutes Q&A.
Adrian, thank you very much for that. That was absolutely fantastic. It was really, really thorough and really, really interesting. In particular, I like how you've put a lot of stuff in there about the grading of the evidence for all that. That's really interesting to see. If you've got any questions on either YouTube or Click Meeting, if you put those questions in the chat box on the side of the screen, then what I'll do is I can relay those uh, to Adrian. I'll just make sure you've all got a minute or so to type those questions in. And in the meantime, I'm just putting the link to our lottery page in those chat boxes as well, just in case you want to have a little bit more, see a little bit more about how you're able to support us.
Of course, the other option is if you want to ask some questions, you can also email them in, and I will try and answer them at a later date.
What's been really nice is the wide array of people that we've got here tonight. I know we've got people from search and rescue, lowland rescue teams. We've got some doctors, and I know there's some mountain rescue doctors who've tuned in from Wales. We've got paramedics, student paramedics, junior doctors. So that's absolutely fantastic to see. Thank you ever so much for all joining in. You may have escaped without any questions, Adrian.
Well, either I was really very, very good, or I lost everybody.
I think it was extremely comprehensive.
All right. Thank you for listening, folks. If there's any questions, if you email them in, I will then answer them in due course.
Thanks very much, everybody. Really appreciate you joining in. If you've logged in with Click Meeting, when I end the webinar tonight, it'll just ask you for a little bit of feedback. So if you could just spend 30 minutes, 30 seconds to a minute of just popping some feedback in, things that were good, things that you'd like us to do differently, or things that you would like us to cover, that would be really, really helpful for us going forward. And don't forget, if you want to do a journal club with us, then please just send me an email and we can arrange that for you. So thank you very much, everybody. Hope you all have a lovely evening. Take care. Bye bye.